Thank you, Dr. Heinrich. Now it gives me great pleasure to introduce our last speaker, who is Nora Super. She is the Director of Federal Government Relations, Health and Long-Term Care at the AARP. And she also, like all of our speakers, have been very involved in healthcare reform and a champion for seniors in this case and their issues. But again, we've asked Nora to give us a heads up on what she thinks we should be aware of and be involved with in terms of the Hispanic healthcare to come with the implementation of healthcare reform. Nora?
Good afternoon, everyone, and apologies for my voice. I've been traveling a lot, and I seem to have picked up something along the way on an airplane or something, so I hope that my voice carries okay. AARP, as you all may know, is a membership organization for anyone who's 50 plus, so we hear from people who turn 50, they hate that. They get an AARP invitation in the mail. It no longer stands for anything anymore. It used to be the American Association of Retired Persons, but over half of our members are working still, so you don't have to be retired, and you only have to be 50. So, of course, most people over 50 are still working. So we focused a lot in the health reform debate on the uninsured as well, but since Dr. Graham talked about how many of the provisions and you all know a lot of the data about Hispanics and how they are the minority group that has the highest prevalence of uninsurance. I won't talk about that as much in my remarks. I'm going to focus mainly on the Medicare population because we haven't talked about that as much in any of the panelists. But I do have in my slides, which I understand we're going to email to people, some facts and figures about the uninsured. But I am at the end just going to talk about the high-risk pools that are up and running now, so you all can get some information about that, because I think that is something that's really exciting and something that's happening right now, and it's a little different depending on where you live and what is available to people, especially people that have pre-existing conditions and have been previously uninsured. So a lot of Hispanics would be able to take advantage of this. For the Medicare population, there were a lot of issues and things that AARP championed. One of the things, of course, that was a big improvement that will go into effect in January is that there'll be no co-payments or deductibles for preventive care. And this is something that will be really important for folks on Medicare to make sure that they get their diabetes screenings and their checkups to make sure that they can have many of the things, the necessary preventive care that they need. Now, as Dr. Graham stated earlier, we know that Hispanics are almost twice as likely as non-Hispanic whites to have diabetes and are less likely to receive needed services and screening to prevent and manage diabetes, so detecting it early should be helpful. This is also true in the insured population. There will be changes beginning in 2014 for new health plans under the Affordable Care Act. But even Hispanics who have health insurance haven't gone in for preventive screenings as much as other populations. So there are language barriers and cultural issues that I think we'll have to work on to make sure that people are aware that they should get these preventive screenings. Although cost should no longer be a barrier, which is great news. There are other issues too that we found in the data in a study that was done in 2008 by the Agency for Health Research and Quality, that a quarter of Hispanic adults have never had their cholesterol checked, 2/3 over 50 have never had a colonoscopy, and more than a half of Hispanic women over 40 had not had a mammogram in the previous year. So clearly, it's more than just the cost that's a barrier here, and we'll need to be working more on some education efforts to make sure. And I think that the new law will provide us an opportunity AARP will be working with a lot of physician groups, pharmacist groups, other what we call white coats, to be getting the word out and educating. We have a lot of, I think in your packet you have some of the links for our information. Much of it has also Spanish language access. We have a website that's also all in Spanish, but helping to get the word out to people as these things become available. As Dr. Graham talked about, there's also disparities in immunization rates for influenza and pneumonia vaccines, and that for African Americans and Hispanics, and we need to, again, encourage people to have these immunizations, and cost will no longer be a barrier. So making sure that we continue to offer opportunities for ways that people want to have them either in the workplace, in clinics, sites that's more available, but luckily with the Affordable Care Act it will no longer have any cost sharing associated with it. I want to move to the subject of Medicare Advantage. Many people may know that there were significant changes to the Medicare Advantage program under the Affordable Care Act in the way that it's paid. And beginning next year, the MA plans will be paid more in line with traditional Medicare payments. These are changes that AARP did support over time. There have been many studies by the Medicare Payment Advisory Commission, the Congressional Budget Office, that found that we really weren't getting better quality through the Medicare Advantage plans, but we have been paying about, on average, 13 or 14% more in the Medicare Advantage program than in our traditional Medicare. And so what we'll see is that you'll see a lot of changes based on your geographic location and quality. But one of the things that we did push for that is part of the bill is that plans that provide higher quality will be eligible for bonuses if they achieve at least 4 stars in a 5-star evaluation system. And one of the things, if I had my PowerPoint slides, I could show you this nifty little map to show you how much it varies across the country. But I'll bring this up for you. I did look at some data right before I came to show you. This has sort of been a big debate within the Hispanic community because a lot of Hispanics have been traditionally enrolled in Medicare Advantage plans. More so, I think, because there tends to be higher Medicare Advantage penetration where Hispanics tend to live, more in California, the Florida area. And when you look at the plans that have, what I did before I came was look at those plans that have high quality plans. California, for example, has a lot of high quality plans. The Kaiser Family Foundation studies found that over 45% of enrollees will be still enrolled in plans that are qualified for these quality bonuses. But in Florida, they don't have as high prevalence of quality plans, so there's only 7% of plans. Now, there is a transition program that will allow plans to sort of change their incentives, which is what we want to see, some movement for these plans to become higher quality. And the way, this is a program that CMS has set up to, and they'll be changing it some. In fact, we're going with a group of beneficiaries on Monday to talk to them about how they'll be communicating these quality bonus plans to people, how they'll help consumers choose plans based on quality, how they'll be paying the plans. It'll be a new system, and you'll see, as you'll expect, plans will respond to these incentives and change. But it will be things like how well do you manage someone's diabetes, how well do you respond to customer complaints, how culturally competent are you. I mean, there will be incentives to have plans respond to things that we think are much in the consumer's interest. But we will, I'm sure, also see some plans pull out. You won't see as much high Medicare Advantage penetration as we saw in the past. So I think that you will see changes in these markets. Let me go quickly to the Medicare Part D. The donut hole was something that AARP worked very hard to change. This is the difference between the initial coverage limit when people pay into their premiums for Medicare Part D, and then they reach that coverage limit and they're still paying premiums but receive, they have to pay all of their drug costs up to a certain limit. We were able to make sure that that donut hole will be closed over the 10-year period. And beginning in 2010, well, there'll be a 50% discount on all drugs in the donut hole. So this is a great change in the law. And this year, we've even started seeing some immediate relief where folks that fall into the donut hole are getting $250 rebate checks until the end of the year if they fall into the donut hole. It's just a one-time check, but it's helpful for folks. And again, drug costs are something that we've seen have really prevented folks, especially Hispanics, from getting drugs that they need. A recent study found that more than 20% of Hispanics said they didn't fill a prescription from their doctor because of the cost of the drug. And this was compared with a little less than 13% of non-Hispanics. And so we're hoping that this will be very helpful to with adherence in drugs. I'm just going to close by going quickly to the high-risk pools, and if those of you who don't, as Dr. Graham said, the pre-existing condition has been a big barrier to people who have many of these conditions that Hispanics have typically had to the cost of drugs, and there's a provision in the law that established high-risk pools for people that have been uninsured for at least 6 months or have pre-existing conditions. So beginning July 1st, HHS established something called the Pre-Existing Condition Insurance Plan. States have the option to either set up their own high-risk pool or to allow HHS to establish one for them, a nationally administered one. So 21 states chose to allow HHS to run their high-risk pool, and this new nationwide high-risk pool program is running now, and it covers a broad range of health benefits. All covered benefits are available for you, and even if you have a pre-existing condition and there are no waiting periods, it's actually much better than we thought it would be. I know in Washington terms, we say it only has $5 billion, which, you talk to other people, but, with as much expenses as some of these people have with their high cost, we really didn't think it would go very far, but they were able to. One of the things AARP worked very hard on was age rating bands, and this could go as high as four times as much for age rating bands, but they were able to keep it down to low, like about 2.1 for age rating. So for older Americans trying to find affordable health insurance, it's really a good deal. So, I really encourage you all, if you have constituents who have been uninsured, have pre-existing conditions, to look into your state high-risk pool and see. We've seen premiums for the 55-plus age category ranging from like $500 a month to about $775 a month. I know that sounds like a lot of money, but like in the individual market, that's really, really a good deal compared to what some of these folks have had to pay. The other states have chosen to run their own, and some states, the highest listed premium we ran was Alaska, which was really, really high at about $1,700, but Colorado has one as low as $115 a month. So again, I encourage you all to look into this. Pennsylvania is the only state with a fixed premium for all enrollees, and that's at $285 per month with no age banding. So again, this is a good opportunity for people, and I think that we've been pleasantly surprised at, and not that we didn't think the government could do a good job, but it's just that given the need and want that would be out there for this type of insurance program, that they've been able to really offer good product. So the opportunity to be here.